the cholera seasonality is such that coincides with the onset of rainy season and the end of rainy season. The peak for the transmission period is majorly during seasonality. Hello? Someone is talking?
Please go ahead, sir. Please go ahead, sir.
Okay. So the peak of cholera seasonality is also the peak of rainy season. And then during dry season, we do report very, very minimal number of cases. And that is what is happening currently. But for the year under review, 2025 majorly, the country reported 28,833 suspected cases and 540 deaths. Very shortly, if the internet allows me to share this slide, you'll be able to see how what we call the epidemic curve, how it looks like, and how it corroborates the seasonal pattern. Week one, by week one, we mean the epidemiological week, starts from January and hence in week 52, which is end of December. And for the year under review, we'll see that from week one to up to week, or let's even say from week 7 to like week 21 of that year, we had the lowest transmission of the disease. And then from week 22, which most time coincide with full onset of rainy season, it starts spiking. And for last year, it peaked at week 35 and 36 before, as the rain seems to now be subsiding, you see the cases are dropping, and then until it gets to the barest number reportable for that year. So when we look at the broad, I really, really feel bad that this is not visual for us to appreciate. So for the case fatality rate from the disease in 2025 was 2.3%, whereas all the states in Nigeria, I'm just giving those statistics to start seeing. Maybe when we have more specific questions later on, we'll be able to see how it relates to the work you do and what you may want to make a sense out of this. So all the states in Nigeria, including the FCT, reported at least a case, a confirmed case of cholera in the year under review, and 271 local government areas reported this outbreak. Now, by gender distribution, age and sex distribution of the disease, we also have that slide. And on this, sadly, the age group 14 years and below are the most affected age group, followed by age 15 to 29. And then we have, according to the gender, it's almost like 50-50. Most time it shifts a bit, 48, 52, the proportional distribution of this body across the respective gender. Most times females more affected than male, as it is. All right, so I'm really struggling to see if I can get this thing downloaded. Very strange and unusual. Okay, so then the geographic distribution of the disease is the next slide. And this shows, especially for the year 2025, we had a different trend. And this is one of the ways that if there's some modeling to really help us know what we are to anticipate every year. But this particular year under review, unlike other years, we had Zamfara and Sokoto State being the worst hit states in the distribution. And this was largely due to a lot of insecurity issues in those states. So we have a map that distributed that. Other thing that may be of interest for us is that out of the 36 states that we reported, about 10 of these states are responsible for 97% of the burden of the disease, just 10 of them. And of these 10, Sokoto and Zamfara alone, and if we had Adamawa, we'll be reporting 86% of the burden of the disease in those states that I've just mentioned. And then in the year under review, Zamfara alone was responsible for 62% of the cases. But if we bring it down to local governments disaggregate by the LGA, we'll be able to see that even though we have 774 LGAs in Nigeria, just 15 of them, 15 LGAs, are responsible for 70% of the cases. Now, what does this tell us? This gives us an insight that if we are able to accurately determine where this is going to happen in the affected LGAs, it gives us a good opportunity to prepare better ahead. For instance, the resources can then be conveniently channeled to those places, and then we will not need to bother ourselves extensively in implementing this in other areas. So just 15%, 15 LGAs responsible for 70% of the cases. So we did a bit of trend analysis and compared trend over 5 years, and that's 2021 to the current year, and you'll be able to appreciate that early reporting states in the current year, 2026, for instance, also differ historically from the affected states in the previous year. And this is suggesting a shift in transmission patterns and the emerging risk areas in these states. We did something that we call priority area for multisectoral intervention selection of the LGA. We call it PAMI. And this is in line with the Global Task Force on Cholera Control recommendations. And we identify about 143 LGAs as those hotspot LGAs out of the 774. But even out of these 143, you can see that only about 15 of them are responsible for the majority of the cases. So, but as the pattern is changing again, there's climatic change and every other factor that may be affecting the transmission patterns. We're already seeing this trend, highlighting gaps in our preparedness, early warning, and then wash intervention. By wash, we mean water sanitation and hygiene systems that need targeted interventions for us to be able to move on as expected. All right. Just a minute. I think it's happening. So we would greatly appreciate if we have the opportunity to have a system that can help us conveniently predict the possibility of this disease and where the transmission may happen better across our different zones in the country. I think that would be very, very helpful. In the new year that we are in, we've reported cases already, but like I did say earlier on, it is not as the other years. So the reporting this year is still relatively lower because we also do a comparison by weeks. So when we look at the first few weeks of this year compared to previous year, the transmission seems lower, but even though it's lower, it is happening in those states that are not the usual states that normally give us that kind of burden. So the transmission pattern is really changing. And so understanding the factors responsible for this change will be very helpful if it's something that the modeling can also predict, or maybe if I understand the scope of what the institution does with data or the kind of specific data you need to help you answer the questions you have in mind. Okay, thank God it has delivered now. Professor Bakari, you can check it now. Really, really sorry about this delay. Well, that's the limitation of technology. So when internet is not your friend, it's not your friend. You can't do much. So if you are able to pull it up, sir, I've sent it, and I believe you can see now. So, are you able to see it? I want to wait a bit so that it's easier for people to find.
Hello, sorry, we are just a minute, sir.
Sir?
Yes, sir. Go ahead,
I'll
sir.
just hold on. Okay, I wanted to hold on to be sure that we can all see the slide so that it's easier to follow. Anyway, so let me continue so that we don't keep waiting. So, but if you are there, you can just take from slide 8. But I hope you are able to. So basically, the trend this year and the last 5 years has been very similar, even though we even had lower numbers this year. But we're anticipating that from week 21, 22, as usual, the cases will start spiking from what we have reported. That is speaking to the data. So there's a target for Global Task Force on Cholera Control for all the countries that are affected, to be sure that, are you able to download it?
Yes, sir, we've downloaded, sir.
So if you can project. So the effort to end cholera requires commitment of all stakeholders. And so countries have committed to implementing these evidence-based cholera control plans. There are 3 main axes to ensure that there's early detection and quick response to contain the outbreaks. And we're also having targeted prevention strategies. Not only should we detect it, but we can also make efforts to prevent it, especially by focusing on those hotspots that we now call priority area for multisectoral intervention, LGAs. Then we are also getting support for coordination of human and technical resources from the partner. Yeah, so that's the slide. Then the target is that by 2030, at least 20 countries would have eliminated cholera. If there's a slide there, you can just roll it. You can move it forward just to see the things I've mentioned. Is it my network or your network? Because it's not moving as fast. So 20 countries are being worked upon to eliminate cholera by year 2030, and that's like in the next 6 years. And then, is that a challenge? The slide is not moving, or is it from my side?
No, please go ahead, sir. We are working on it.
So we're saying that by 2030, we want to be sure that cholera is eliminated, not just controlled. You understand? Nigeria is currently at the control stage, where that's why we say the cholera control program. But the target is to be able to eliminate. I'm sure we know the difference between control and elimination, meaning that the disease is no longer found anywhere in the country by that time. And that the next target is that by year 2030, we should be able to have, and that's the global roadmap that I'm describing to us, that we should be able to have 90% reduction in cholera deaths, meaning the case fatality rates from cholera should also not be more than 1%. We currently have about 2.3% to work on. So the regional framework we're adopting aligns GTFCC framework and proposed concrete actions that include, like I mentioned, enhancing epidemiologic and laboratory surveillance, how we can map cholera hotspots by improving on the ones that we already know. Yes, so yes, there's also the national strategic plan that was launched. I can share that with us, which we'll mention shortly, that describes how can you still hear me?
Yes, sir. Yes, sir. We can hear you, sir.
Okay, so you're back now. So if you go back now, the slide, just for people to see the graphic representation of the things I mentioned earlier on. Go back to the beginning. This is the way I wanted the slide to show before. Good. So next slide. Yeah, so this is data, the epic curve that was explained the other time. And you can see the distribution pattern of the disease according to the seasonal changes. And you see when we had much of the death to coincide with when we had more of the cases. So this is always the trend. And you can see that as it dovetails towards the end of the year, it starts picking up in the following year again until it starts rising. Next slide. I've said all of this earlier. So if you go to the other slide, this is distribution across the country, and you can see why it got concentrated in San Francisco State. Next slide. Just a quick graphic to back up the things I've said earlier on. And this is the situation this year. You can see all these, most of the states that are reporting this year, many of them are not in the high body last year, and we're already seeing this change. Next slide. And this is just giving us specifics, and that you can see for this year there's gradual increase in cases from you compare last year, and CFR also exceeded 1% of the outbreak threshold in 12 states, which also gives us concern with case management. But we always have a decline from October. The transmission persisted into this new year by January. Next slide. Yes, this is the last year data that I mentioned, that 97% of the cases are from these 10 states. You can see that these 10 states are not majorly the ones that we started with this year. So this is comparison between 2025 top 10 and 2026 top 10. You can see it side by side, except for Kebbi, maybe Gombe. The rest are largely, maybe Adamawa. The rest are new states, and Bauchi too. Maybe 5 of them summarily. Next slide. So what this is telling us is that the transmission pattern is changing, like I mentioned. I've also discussed this by LGAs, the new LGAs that have been affected, and the high body. Next slide. So quickly, in the interest of time, sorry, we've taken a lot. So this is the trend analysis I told us about over 5 years. I mean, now 6 years. And you can see that this trend is always the same, even though this year, 2025 2026, the lines are still lower than previous years. The cholera has a seasonal pattern with respect to supposed immunity that is conferred on the population following a major outbreak. And this is consistent with the what we see when populations are vaccinated. For instance, when populations are vaccinated, we have about 3 years. If they have their 2 doses of vaccines, they have 3 years immunity, and after 3 years, it went off, and you start seeing major outbreak again. So, if you with the last major outbreak, 2021. So 2024 had another spike. So we expect a bit of respite in 2025, 2026 until maybe 2027, 2028. But we have the opportunity to really capitalize on the successes and then prevent the surge that we expect. So there is gap in preparedness, early warning, and watch systems that require intervention. Next slide, quickly. Okay, like I said, please take note of the questions on the kind of data you require to have, if it is something that we collect currently. Next slide. So this is always how the map looks like in the beginning of the year. And then by the end of the year, you start seeing what I showed us earlier on, that has San Francisco as the high body. And this is the roadmap that we are following, that I'm just explaining about having 90% reduction, and that we should be part of the countries, 20 countries that will eliminate cholera by 2030, which is very possible because cholera is a disease so easily treatable. So the regional framework is the next slide that tells us how we're adapting this. Next slide quickly. And this is the framework that speaks to how we can enhance our epidemiologic and laboratory surveillance. And that is where this modeling can really help, how we map our hotspots. Then the rest will be how we translate this kind of intervention to improving access to timely treatment. You can pick the cases early, case management infrastructure is well strengthened. Then partnership and community engagement to ensure that we can prevent the disease, and the health-seeking behavior of the people can be improved upon. Investment in clean water sanitation, because the major driver of this disease, as we know, is when there's fecal contamination of the water sources. And the water pathway of the people, if you get contaminated, then they have no choice. The disease keeps spreading. This has been responsible for increased vulnerabilities in the communities and all of that in research. Next slide. So how do we do with the country? We have the National Strategic Action Plan that has been launched, for a cholera plan of action for cholera control 2025 to 2029. Next slide. And this is in line with the global roadmap, which I showed us earlier on. And so next slide, it's just showing us so like I said, I'm going to share the plan with us in this figure. So the current intervention has 9 pillars of our response. So when we activate our emergency operations center, we have this structure, subject matter experts across the CWG, focusing on leadership and coordination, surveillance, lab, case management, IPC, oral cholera vaccine, wash interventions, risk communication, and community engagement. What's the perception of the people? And then how do we address infodemic management? So risk communication and community engagement, logistics, and then research. Next slide. And so our own strategy is just in line with what I've said, which our focus is to reduce morbidity and mortality using the following objectives: to strengthen the surveillance and detection, improve wash capacity for lab and community engagement. Next slide. So this is a PAMI conversation. That is next slide, priority area for multi-sectoral intervention. But when we look at the map of the country, we use administrative and demographic data per health GA across 6 years. Reported cases and cholera deaths, cholera testing data. It also takes into consideration vulnerability factors based on the data available and expert qualitative opinions. What makes the community vulnerable? Their access to water, sanitation, and hygiene facilities, their travel routes. You see that communities that have more, people traveling through their routes, or like is a hotspot, like a hub for travelers, maybe across north and south. We have places like that in Ibadan. People coming from the north first stop at Akinyele before they move on to Lagos. Those coming from Lagos stop at Akinyele, they exchange like that. So Ibadan is the kind of hub like that. So ditto for some other states like that have that mix. Those are vulnerabilities, and also the peculiar climate events in their area. Then we also use GTFCC tools, which develop a priority index scoring the health GAs based on what has been the cholera incidence, mortality, persistence, and this factor in their LGs. All of these led to the experts coming to a consensus to set the priority threshold score at 7, and these helped identify 134, I said earlier 143, 134 LGs, representing 17.7% of our population, has been accountable for about 71% of our cholera cases and 65.5% of deaths. And that's what the graph on the left, the right rather, is showing us. You can see the states that are considered very high risk, then those are the one in red, then the pink high risk, moderate risk are yellow, and states as low risk are predominantly the Southwest states. And when we look at that, you can see that these vulnerability factors are more present in those states of the north. It used to be cholera of the south, but it's now cholera of the north. But a lot of things are still changing. Next slide. So the next is what our response has been like at the national level. When we declare outbreak, both at national and subnational level, we activate what we call incident management system. We strengthen risk communication and community engagement activities across all levels. We support capacity building, give them SOPs and guidelines as subnational stakeholders. And where required, when the states are overwhelmed, we deploy national rapid response team to support them in those states. Periodically, we do conduct what we call intra and after action review that helps us to understand both at the national and the subnational level how well have we fared in the response, what worked well, what worked less, and what we need, what are the bottlenecks. All of these will help to develop the improvement plan and improvement actions against the next outbreak wave. One of the key game changer is the deployment of oral cholera vaccines in affected communities, which also serve as stopgap, pending when it helps break the transmission, which now allows the stakeholders, the government, to be able to provide the needed resources for more infrastructure-related interventions that relate to water, sanitation, and hygiene. Then we also have a national cholera research agenda that has now been developed to help us understand more about the drivers and peculiarities of this transmission. Operational progress, talked a bit around this. We have a multi-sectoral, multidisciplinary technical working group, both at the national and subnational level for coordination. We receive technical and financial support from partner organizations, as you can see on the screen. Availability of national incidents plan is also one of the ways to guide us in addressing the outbreak. Next slide. So for water, sanitation, and hygiene, which is the core, next slide, core area of challenge, there is Rural Water Sanitation Agency in every state. So they support in the conduct of chlorination of water sources and bodies. Provision of aqua taps, those are the tablets to use in disinfecting or the contaminated water. So the concept is that if you cannot give them water that is clean, at least you should be able to make the one they have very, very safe for use. So aqua tabs are being distributed to those states. Cholera kits are also distributed to states to help them have their oral rehydration salts so that they can quickly rehydrate themselves. We also have what we call the concept of CATI, case area targeted intervention, where about 30 persons in 24 ages were reached with key messages. So we have some mapped area where the intervention actually is being implemented in those areas to interrupt transmission. Sanitary facilities, one of the challenges with cholera is open defecation. We want to be sure that our cholera treatment centers have sanitary facilities, and then toilets has been a major concern. And so toilet facilities, but we'll continue to advocate for more of these. In some other affected states, potable water are provided through commercial vendors, and then supported the repairs of broken pipes, because most times you find that there is a road construction that affects water pipes in those communities, and then water shortage follows, or their water is contaminated when the rain falls. Risk communication and community engagement is another strong area that UNICEF is supporting us in ensuring that we have the relevant dialogue and conversation around this disease for more people to be informed, and such that they can take informed decisions. For case management, to ensure that this is a disease that is so easily treatable. And that is one reason that I've said different times that there's no justifiable reason for anybody to die of cholera. So if they can present early, we have our CTC and CTU. CTC means cholera treatment centers. CTU means cholera treatment unit, and ORPs means oral rehydration points. Rehydration points are what could be in every community, so we can map the communities to see where we need to put rehydration points based on the vulnerabilities in those areas and the burden of the disease, and then equip them with what they need to quickly rehydrate the cases when they present. The healthcare workers have been trained to understand the cases, like understanding the case definition, and then they can manage very well. We also provide them with drugs and medical consumables, including ceftriaxone, metronidazole, doxycycline, rehydration salts, and all that. Next slide. So we supported interlearning exchange for state epidemiology. So there are instances that we ask state epidemiologists from one state that are very good to go and support other states, and in that regard. Next slide. As I close, so that we can take quick questions. Apologies, we have wasted we lost about 15 minutes trying to. So on this operational progress and alignment with the priorities, we support national response, active case search for states that are under-reporting, because there are some states that are traditionally known for outbreak of cholera, but we suddenly started seeing that they are not reporting again. So because we all know what's the situation with cholera, most people don't like to report the cases. You understand? And then it is always challenging because they'll see it that it is a disease of poverty, and that people cannot provide, the government cannot provide potable water for their indigents. So that has been a major challenge. We also have operational readiness and response plan WHO has provided that is also guiding their own support, and they ensure that this is aligned with the country's roadmap. And finally, these are the risk factor. Next slide. It shows us the cholera and drivers in Nigeria. I think there's a request on this to understand what are those risk factors, so that we can see how to do our modeling around a number of these. We also noticed issues around seasonal climate, seasonal changes affecting spread. Of course, open defecation, lack of proper sanitation leading to contamination of water sources and food items. Mentioned infrastructure, poor hygiene, insufficient hand washing and sanitation habits. And then increased population movement could also be responsible. If we have if there is insecurity and there is internally displaced persons camp, there's increased risk of transmission of disease based on the migration. Also, agricultural practices, farming methods contributing to water contamination have also been identified. And of course, socioeconomic factors, poverty, inequitable access to water, clean water. It's also a challenge. Next slide. In conclusion, I talk about the challenges that we have. Preparedness in response to cholera outbreaks. We normally don't have resources to help us predict appropriately where the cases are going to happen. And then how to really prepare would have been a lot easier. And this is associated with delayed detection and notification. Some also get the cases, they don't report. And that's why we intend to have the facilities, the states, if they are pre-informed, for instance, through some modeling to let them know that this is going to happen in your state around this period. Excuse me. It's going to happen around this period, and it makes it easier for the government to be better prepared when we issue advisories to them. And a couple of other challenges, encouraging the state to be able to report early, and then having fund for preparedness and interventions. Next slide. Lessons that we have learned also identified in the last slide. And we have our suggested solutions on the next slide. I need to close, which can also be, next slide, suggested solutions on RCC efforts, repositioning of commodities, adequate vaccines, capacity building for health workers, cost efficiency and smart interventions need to be demonstrated and shown the government people, stakeholders as a key success, especially when there is limited financing. Also, next slide, state leadership need to be engaged, and we are doing that for them to clear outbreak early and activate their incident management system, and the more partners alignment, especially like we are having this discussion, and we look forward to more of such alignment of plans so that the contributions from this institution, for instance, how we can ensure that it helps improve our detection and then contributes to reporting and also prevention of this disease. Next slide. You can skip the next slide. That's for another group. Next slide. The last slide is just last slide. Next slide. No, before this, just saying, no, we're done with this. It's just the last slide here that I have emphasized in different media appearances, whether on Arise TV or to say that we all need our efforts, do our parts before the outbreak starts. And that is why this modeling conversation is very apt to be able to just comfortably help us predict what we should look forward to, who will be affected, where the interventions need to be, because I've said no justifiable reason for anyone to die from cholera for a disease that is easily treatable and preventing. If there are other specific questions, I'll be happy to provide insights. Thank you very much, distinguished leaders. Over.
Let's give a round of applause, please. Thank you very much for your Duoguni. First of all,
The volume is on your side is a bit low. I don't know.
okay, so thank you. And then let's see online participants if there are questions. And then from anyone here, questions? 1, 2, 3. Is it that people are not interested in cholera? Okay, 3. People are okay. Yeah, let's see the people online. Nobody. Okay. So, Thompson, Boom, then Gabriel. Come and ask your question.
Thank you very much. And thank you, Doctor, for your presentation. So, my question is around how the data, probably there's availability of data regarding the intervention of WASH, which you mentioned. Yes, sir. So my question is around availability of data, how the data is collected for WASH intervention that is implemented for cholera, and also are there available data for ORV, that's OC, oral cholera vaccine? Yeah, that's over.
Do you hear his question?
Yes, I got the question. Thank you, sir. I got something like, how is data collected for WASH? Is that the question? Hello, did you say if we have data for WASH, or how is the data collected?
Okay, they collected 2 questions. 2 in 1.
Okay, there's data for water, sanitation, and hygiene. And I will refer us to the current survey that was done, call it WASH norm. The document is available online. WASH, WASHNORM, WASH norm. I can get that analysis and then share with us also. So there's data for WASH, and the detailed explanation of the methodology for the evaluation and the survey are also captured there for ease of reference. I'll share that with us. I've taken notes.
All right. What's OCB?
By the way, we have a separate ministry across our stakeholder that deals with the water, sanitation, and hygiene, and that's the Ministry of Water Resources. They're also in each state. That is called the RUWASA. I'm sure Ekiti State will have one, and they can also be partnered with in addressing this. Then you asked about OCV. I didn't get that question.
How you the data for OCV collected?
How is OCV collected?
Yes.
OCV is oral cholera vaccination. It's a campaign.
The data itself.
Data for vaccination. As in to know those who are vaccinated.
Yes.
Okay, so the National Primary Healthcare Development Agency have the structures of doing what they call the micro planning. It's not different from the other immunization activities for reactive vaccination or also for preventive vaccination, but mostly it's for reactive vaccination. So they map those areas, they have the micro plans of the affected population. So when we give them the data around the affected LGAs, and then they do their home part by identifying the vaccine quantity they will need based on the data we give them of those affected and are confirmed. And that will be used to deploy the vaccination campaign to those states and the affected LGs. And then they carry out their vaccination and then report the coverage of where they covered based on what they set out to do and what they were able to cover based on the post-vaccination evaluation that they do. That's what I understand about the process, unless there is any other specific details you require. Thank you.
All right. Thank you, Dr. Oni. So my question is, firstly, I want to thank you for the beautiful presentation and quite insightful, and it's really helped us as modelers to see how we can come in to solve some of these problems associated with cholera and eliminating them in Nigeria. So my question is that you mentioned, we talked about infodemic management. I would really love you to shed more light on some of the misinformation. Okay? I really want you to shed more light on the misinformation associated with cholera and how exactly is the NCDC managing such infodemics? Thank you.
All right, thank you very much. So as we know, with the concept of infodemics, which speaks about having no super abundance of information out there, people are now at liberty to use it against or use it anyhow for their own aim. So when it is misinformation, it is described as unintended use of such information. It can cause harm. You're using the information to cause harm, but it was not intentional. So when you disseminate such information to cause harm, but you are not doing it deliberately, it is misinformation. But when you do it deliberately to cause harm, it is disinformation. So we see those who we start the initiative with, is about the initiative anyway, with the intent to cause harm, maybe for their own gain, because they believe that bad news travel faster than good. So you see people reel out information that are not correct, such that people can start sharing the information for their own benefit. You start seeing people saying, share this now to your family, share it on your group, share this and that, causing panic here and there. And I give a quick example of that. When we were vaccinating people in the recent state that affected last year, I think it was San Sokoto. One of the battles, even Adamawa, one of the issues they confronted was about misinformation was people, if they are vaccinated, it will affect them conceiving in the future. Secondly, they said when they contaminate their water, that it can also lead to sterility. And so the contaminated water is already containing certain chemicals that could affect their sites, that could. So all of those things we have the system across all the states. We have the health promotion officers, health education officers who are trained in risk communication and community engagement. We have infodemic managers in the state. And there are structures in the state to capture this information. So when gather them, we analyze them, where are they coming from, what are their intents. Then we're able to reach out through community structures and other identified collaborations at the state and LGA level to interact and then allay fears. But better it is done before the outbreak, because when people are already in panic mode, their ability to reason appropriately can be impaired. We all may recall 2014. I was one of the first responders to Ebola outbreak in Nigeria in 2014, so I know firsthand what we went through when people were drinking salt and water, and they said that it is something that can cure Ebola. It was not a problem for market women doing it. I don't find that any challenge. But they became worrisome and disturbing when healthcare workers were sharing the same information. So nobody bothered to ask, what is the relationship between drinking salty water and killing a virus? Are they in the same? Is it a disease affected by the gastrointestinal tract that is sought to go and meet it inside your tummy and destroy it? Nobody bothered to look at their medical training to ask that if I bathe with salt water and it will kill the virus on my body, what about the one inside? People are just out of panic sharing that. So the lesson from that is to ensure that people are equipped ahead with the right information, what they need to know, where they need to turn to get the right information, what are the credible sources for their information. That is very important, so that when anybody sends rubbish to them, and that happens in different places, especially with this advent of social media, it's easy to just share. Can you fact check? Everybody wants to fact check the information being given to them. They are eager to just push it to the next person. Unfortunately, when you come back to them with the good information, they won't share it. It won't trend. But the bad one will trend. All you just need to say is that something bad is happening somewhere, and tell your loved ones, don't do this, don't do that. Then, so it's a very big challenge, and it requires all of society approach to ensure that we can really tame this. But we have structures, people are being trained periodically, being supported. But you know, even in the US, not only in Nigeria, infodemics is a key issue. You remember during vaccine COVID, they said if you get vaccinated, the site can magnetize objects. If you put light bulb, it can show light. It's a sign of CDS, CCCs. Did anybody try? Even when they try to, with this day of AI now, it's even worse because they can even do it and make it look real. So it's very challenging, but we believe with our continuous support and effort, we'll keep winning more to our side. And if we are more proactive, we'll be better prepared and we can conveniently build the community resilience before the emergency. Thank you.
Thank you, Dr. Oguni. Next person.
Right, thank you, sir, for your presentation. I want to ask concerning the data also, because many times when you go online, get data, especially on the Nigerian Center for Disease Control, you seem to see data that is outdated. So, I mean, like data that it might not be outdated in the context, but it's like a long ago data that may not capture the current situation. So how do we do in that situation? Then number two, the point you said, need for research, and when you go online again, you see that there are so much research that are being done, especially in the Nigerian context, in line with Corella. So I don't know whether there has not been any such research that the government could have adopted. What if there was none? Yes, if there is none, what has been the challenge, or like what has been the gaps? I don't know if the question is clear.
Okay, I think I pieced some information together from what you said. So, first, data not being real time enough or not being current enough, maybe for policymaker Maybe today, if you go to the website, you're expecting to see data as at. How are you doing? So, sorry, if you go to that website, you will definitely not find data uploaded there as at last week or last month or time. So even though we're trying to update that, but we've seen that people just go to the website, gather data, and start analyzing it and using it for their I don't want to say selfish, for their ulterior motives, and without even calling back to the organization for proper guidance on usage, data privacy, data quality issues become a major concern. So, but for the purpose of this institution and what we plan to do, when we go into such partnership, it will be a lot easier to officially, and what we do now is we expect anybody that wants to have data from the organization on any of the disease of interest to write. Then from the data repository, we have all the data that's very current. They can be officially provided for them, and that can help address the areas of interest, especially if it has the variables of interest. And we are eager to say that if for your organization there are diseases that we are monitoring that you require additional variables to help you, if it is something that is easy to quickly integrate, fine. Because what we have seen is that at the organizational level, most health facilities and ministries are reluctant in collecting extra data. You know, the challenge in filling forms for Nigerians and mostly people. So that's about that. If you need any recent data, it's for the institution to write, and then the leadership can look at how well the collaboration can yield what is going to be a win-win for the country while adhering to necessary institutional framework for data usage. Then you talk about research. That wasn't so clear, but what I got from that is, of course, I mentioned in my presentation there are many things that we know already about cholera. I just showed us the drivers. However, we may want to also do additional research into identifying, okay, why are the interventions not working, for instance? And there may be other qualitative studies or quantitative study that we just want to deploy in identifying, for instance, we are vaccinating people and we are also still seeing cases increasing in those areas. What does the vaccine efficacy study say? What does the vaccine efficiency say? There are things we're not getting right that we need to address. Why are people not taking up our interventions seriously? So there are different other research questions that we've identified of recent. For instance, it can be as little as rapid diagnostic test kits. Why are people not willing to test? Okay, because we need them to test for us to be able to utilize the data for even requesting for oral cholera vaccines. Why are people not testing? Okay, when states are not deploying, they're not ready to declare outbreak. The root cause analysis of problems statement is also something we can key into. So whereas there are already existing information about researches, there's always opportunity for more. That's why we have a research agenda that we expect. There are a lot of research questions that researchers may be interested in supporting. Thank you very much.
Yeah, thank you. Thank you, Dr. Hui. I have a list of questions here. What is the It's been very difficult for us to find out to really penetrate NCDC.
I'm really struggling to hear you, sir.
Okay, so it's been very challenging for us to penetrate NCDC in terms of assessing data and all that. I remember that we are there several times, myself and some of my students, and we could not get through. And thank God we were able to meet you, at least to even give us audience to talk to us like this. I was very happy hearing you because some of the diseases that NCDC are capturing, they are actually epidemic-prone disease that is of great interest to us because we are in Nigeria and said in supporting NCDC with modeling results or outputs, as we have been doing for, I must tell you, we have been National Malaria Modeling Consult for NMEP for the past 2 years now. And we've been working together. We have published a lot of work together, and we are still doing it. So I was also thinking that we are going to be able to repeat that for NCDC. And going forward, some of the questions you have raised in terms of modeling is what we have capacity for. But the challenge is when you go to your platform, the situation, the dashboard, you hardly find enough data. Most of the data are basically national level, and they have a lot of missing data. And then most of them are basically on cases. You don't have a lot of information that can be useful to answer meaningful modeling, epidemiological modeling question that can be used to inform policies and also drive some decisions. So I feel that some of the things you have said today, we have seen the need for data on, especially when it comes to special issues that you mentioned, being able to predict where is the next place that the disease and the outbreak is going to occur. These are questions that modeling can be of help when it comes to geospatial models. For us to do some of these things, we need a lot of data. And then a lot of other things can also be done in terms of knowing the timing of the peak, in different states that those things are happening. And then, and also in terms of the aspect of cost effectiveness analysis, it's also an important area to look into. So I feel that just like we do with a National Malaria Elimination Program, the National Cholera Operation Research Agenda will be a very good platform to assess some of the research interests that may concern modeling and all that. But I think we can start from anywhere. Like some of the students that have asked questions here, some of them are working on cholera, measles, CSM. There are people working on CSM, but we have only been making the data we can lay hands on. So if you get better data that is well stratified, that has KC, that has different heterogeneities like age and sex and socioeconomic status and even climate, like we know that the drivers of the seasonality for cholera is the major one is precipitation. And this is very important for us to look into, going forward. So I believe that a lot of things can be done. As I'm sitting down, I have written a lot of things down, and there are many things that can be done. I just see that NCDC just collecting data and we are not using it for anything. So I feel that we should move to that point where there can be a collaboration, a strong one, just like we had with NMEP. A strong collaboration with also we have with Federal Ministry of Health, that's the NTD group, neglected tropical disease. I have students who are working on FDS and TISTO, and so I feel that this can be strengthened, and then we can begin to do some meaningful things together going forward. So I would like to hear your response. Over.
Okay, thank you very much, Prof. So yes, like I did mention, we identified that this has been a challenge, and most times data governance issues have been a bit controversial on how well the institutions hold their data. And this is not peculiar to NCDC. You see, every organization just keep their data. And I agree with you that it's of no use collecting data and not using it, or let me say collaborating with those who can help you make good sense out of the data you're collecting. What I would say is that if the organization, now I've given the presentation, you've seen what we do with this disease. You've seen the data we collect, basically epidemiologic data, demographic data, locations where things are happening. Then it's for you to now say, okay, based on the modeling you want to do, the epidemiologic modeling, what kind of data will you require? And then what do you intend to make out of it? What are the benefits of such collaboration? So this, if written as an institution to the agency, copying us, because to be written to the GNCDC, then we are able to then facilitate the conversation to engage leadership to say, okay, this organization, these are the XYZ they have done before, this is the antecedent, and they want to support us to do this and that. And I've seen such mails sent to the DG by some organization like UNICEF, and they have been able to, DG has been able to, within a short time, provided a response to it. It will ask all the departments involved to say, okay, advice, what do you think about this? And it gets solutions to, they get response that are more acceptable to them. So I would say on this, it is important to share the idea you have in mind, like we've had this meeting now. Following this meeting, what do you think you can do for cholera with respect to this interaction? What information will you require? Then you can be guided on how to go about it. But like I always say, let's think about what is going to be helpful, especially before the outbreak starts. Or it depends on what level of intervention we are looking at, whether it's something that we can achieve before the outbreak starts or after, or along the line, or towards the end of the outbreak. So based on the seasonal patterns, you'll be able to say which one do you think we need to first prioritize, so that we start somewhere. We don't need to ask for, like, for times there may be data you're asking for that we may not have. Somebody can come and say, like somebody said, can NCDC give me data for 10 years? I want to use for a study. You don't just come and ask people's data and then without understanding how does this benefit the organization. So there is organizational framework and governance structure for data. In fact, we have a research governance unit, and all of this will be shared with us moving forward. Thank you.
Thank you very much for that information. I think we'll take it up from there, and then we'll see how this relationship can grow. Thank you very much. So I want, I don't know if there is any other thing. In the absence of no other thing, can we give him another round of applause? So we really appreciate your time, and we believe that something is going to start from here, a collaboration that is going to lead to meaningful results and solutions to what is going on as regards cholera in Nigeria. So we hope that we'll still work together. Thank you for your time and have a good evening. Thank you.
Okay. Thank you so much.
Yeah, so we also appreciate all the online participants for coming. Thank you very much. So we hope next time you are going to come and then you ask questions. Thank you, and also have a good evening. Thank you.
Thank you. Bye, everyone. Thank you, bro.